Let's go ahead and get started. Um, good morning, afternoon, or evening again. Thank you very much for joining us in this webinar. We're very happy to be co-hosting this webinar with our partners over at the CBM Global Disability Inclusion on the topic of human rights-based approaches to mental health in the Asia Pacific. It's been a while since we've done a webinar, so do mind if there are any sort of hiccups along the way. But we're very excited to have a bunch of really prolific speakers in their own rights to joining us today. So I'm going to just go straight into introducing the person who's going to be moderating this session for us today. Ben Adams is the Mental Health and Psychosocial Disability Director at CBM Global. Ben brings over a decade of experience working across Africa, Asia, and Europe to advance inclusive rights-based mental health system reform. Prior to his current role, Ben also worked at the World Health Organization, supporting the special initiative for mental health and suicide prevention efforts in multiple countries. I'm going to hand it over to you, Ben, to help guide us through the rest of the session.
Thanks, Glenn. Great to be here. Sorry, can you hear me?
Yes, we can.
Yeah, okay. Hey. Hello, everyone, and warm greetings from Ireland, which is surprisingly warm, actually, today. And forgive me, it is early here, as I'm sure it is for many of you. But good morning, good afternoon. It's fantastic to see such a diverse audience that we have today, from policymakers to representatives of organizations of persons with disabilities and people with lived experience. So thank you all for being here. Today we're talking about a profound shift, I suppose, that has been and is underway, but is really growing momentum more recently in mental health, which is a move away, I suppose, from outdated institutional models towards approaches that respect each person's rights and autonomy. And at the core of this is human rights-based approaches, and one that supports people with psychosocial disabilities to lead full lives in their community. And before we dive into examples, I suppose, from different countries, we have some fantastic speakers with us today. I think it's important that we have a shared understanding of some of the key terms and concepts that will more than likely repeatedly come up through the session. Mental health. So I suppose, what do we mean by this? And this can often be quite contentious, but I think if we can just agree to define it for the purposes of this call, it would be quite helpful. At CBM Global, we refer to mental health as a positive state of well-being that all people have. And it can be nurtured and protected even in the face of adversity. And mental health is shaped by a wide range of factors: personal, cultural, social, economic, political, environmental, the list goes on. And at CBM Global, we really use this term intentionally, and it's not to reinforce outdated models, but it's to reclaim and redefine it through a human rights lens, through lived experience, and through inclusion. And we really see mental health as a bridge between, I suppose, individual well-being and systemic transformation. The next term that you will hear a lot is psychosocial disability, and this is our preferred term. So psychosocial disability is consistent with the global disability movement and their preference, and it refers to people who, regardless of diagnosis or self-identification, face barriers to participation and the exercise of their rights due to social responses and to actual or perceived differences in mental health or behavior or emotional expression. It's grounded in the social model of disability, which recognizes that it's not a person's condition that causes exclusion, but it's the stigma, discrimination, and systemic exclusion and barriers imposed by society. The term challenges deficit-based language and affirms that the disabling impact of mental health is a result of social and environmental constructs. So people may describe themselves in many ways, such as survivors, service users, or persons with lived experience. But the term psychosocial disability helps to speak across systems, it centers rights, and it connects individual experience with collective advocacy for inclusion and justice. And finally, deinstitutionalization. So deinstitutionalization really means moving away from institutional care towards community-based support and approaches. In the mental health context, deinstitutionalization is the process of shifting from long-stay psychiatric institutions to these community-based and community-rooted alternatives. For much of, I suppose, the last century, people with mental health conditions have often been confined in large institutions and psychiatric hospitals, typically far removed from communities and families. We now know that this has often led to neglect, coercion, and human rights violations. Today, guided by human rights standards like Article 19 of the CRPD, which is the right to live independently and to be included in the community, many countries around the world are embracing deinstitutionalization. So they're really developing community-based alternatives that allow people to get support while living in their homes and in their communities. In the Asia Pacific region, movements for deinstitutionalization and recovery-orientated community care are really gaining momentum. And this shift is crucial. It's really about recognizing that everyone has the right to autonomy, freedom of choice, employment, education, and community life, and that quality mental health support can be provided in inclusive, recovery-orientated, and rights-based ways outside of institutions. Okay. Now that we've clarified these terms, I'd like to highlight briefly, and I'll try and be as brief as I can, CBM Global's approach to mental health and psychosocial disability. It's an approach that we hope is and will help to drive this shift across the region. And we have recently developed our 2025 to 2030 mental health and psychosocial disability strategic framework to guide our work, which we will be launching soon. And our approach is really grounded in human rights principles, and I suppose decades of experience working alongside people with disabilities. So it's very much informed by that history. In practical terms, we take a rights-based approach. That means we view people not as passive recipients of services or supports, but as rights holders who must be central in decisions about their own lives. So a rights-based approach also means expanding our focus beyond medical treatment. And we aim to facilitate access to all basic rights and opportunities that, I suppose, enable a good life. So we're not just talking about healthcare, we're talking about justice, education, decent work or livelihoods, safe housing, family life, community participation. And in addition to accessible health and social services. In other words, good mental health support must address the whole person in their context, in their community. And it's about inclusion and equality, not just about symptom reduction or symptom management. We have 5 key, I suppose, elements, if you like, that we really want to emphasize in our work going forward and are key parts of our 2025-2030 strategy. First is around meaningful participation and co-creation with people with lived experience. So really working in partnership with individuals and user-led organizations is at the heart of this work. And CBM supports partners with OPDs and self-advocacy groups led by people with psychosocial disabilities. And working with OPDs is really at the heart of our work. We are committed to shifting power to organizations of people with psychosocial disabilities in the countries where we work. And this means people with lived experience are shaping the initiatives and projects that we implement from design right through to monitoring and evaluation. The voices and expertise and preferences of people with lived experience really guide what we do. And these partnerships also help to ensure that what we are doing is culturally appropriate and that we are held to account and really meeting the needs on the ground. It also builds local leadership for mental health. So, for example, we have helped to establish and strengthen user or survivor networks For example, the National Association of People with Psychosocial Disabilities in Zimbabwe. And we have supported emerging leaders in many countries by co-creating programs with those affected. We really hope to ensure dignity and choices aren't just, I suppose, concepts, but they're real practices. Another area is around community-rooted support and inclusion. So this is where we really see the move away from institutions and how we're hoping to support that going forward. Our approach is obviously very much community-based, and we work to bring support as close to people, to where people live, in their homes and villages, rather than in urban centres or institutions. Community-rooted care can often include outreach by local mental health lay health workers, peer support groups, peer counsellors, inclusive education and employment opportunities. There are lots of things we can do at a community level. We often will partner with organisations and people with lived experience in communities to raise awareness and to reduce stigma so that people are included instead of excluded and discriminated. And we will often help communities to organise support structures. So for instance, helping to set up self-help groups or community mental health committees. And by building, I think, solutions, I suppose, with communities, we can offer genuine alternatives to segregated institutional care, which really contributes to the broader agenda of deinstitutionalisation, as it demonstrates that no one needs to be locked away. A community-rooted model not only provides care, but it also promotes belonging. It allows people to stay connected with their families, to work, to go to school, and to participate in community life like anyone else. In the long term, it also has a greater benefit on the economy than institutional care, which is, I think, a really important point, and one that we should all be mindful of in our advocacy in this area. Ultimately, it's about realising the right of people with psychosocial disabilities to live independently and to be included as envisaged by the CRPD. We also work at the system level. So I suppose we work at multiple levels to drive change. On one hand, we empower individuals and facilities on the ground, helping people learn about their rights and build confidence and to organise. We support local groups to strengthen their voice, for example, by training advocates in storytelling or leadership. And we use the evidence from community projects to influence broader system level change. And in this instance, you will see that we would collaborate with governments to improve policies, legislation and funding for mental health. By demonstrating what is possible through community-based cross-sectorial programming, we can really support authorities to scale up inclusive services, and also facilitate deinstitutionalisation. So in practice, this might mean advising a Ministry of Health on developing a national mental health plan or working with local health authorities to train primary care workers. We also contribute to global and regional advocacy, for instance, engaging in forums like the United Nations or the WHO to push for human rights-based mental health reform. I suppose the main point here is that we connect both grassroots and policymakers. We know that lasting change needs to be both bottom up and top down. So we bridge community action and system reform. And I think it's really important that we all try to do that in our work. Don't worry, I'm nearly there. I'm aware that I might be running a bit over time. We also really reject coercive and purely biomedical models. So this is a core principle for us and a core principle of human rights-based mental health. Is that, of course, it should never deprive someone of their rights. And sadly, in the old paradigm, it was common to see practices like forced hospitalization or treatment without consent, restraint, and seclusion. We almost reject such coercive approaches, and we must support person-centered, recovery-orientated practices that respect each individual's will and preferences. And this means offering support options and letting people choose what works best for them, whether it's counselling or creative therapies or rights-based traditional practices. People really have the right to access a full range of culturally grounded and non-coercive supports when and how they choose. In our programs, we champion alternatives to force and coercion. So, for example, crisis services run in the community, advanced directives where people can state their treatment preferences, and training healthcare providers in trauma-informed care. We also challenge the one-size-fits-all mindset that often comes with a purely biomedical model. Our ultimate vision is that mental health care that heals and supports never harms or strips away someone's agency. I'm nearly there. Locally led and culturally responsive solutions are a focus of CBM Global's work. Local leadership and contextually appropriate models are something that we have really chosen to prioritize in our most recent framework. We must invest in locally led innovation, and we must channel resources and decision-making power to local organizations, community leaders, and people with lived experience who best understand their context. So localizing power and practice is one of our strategic priorities, and by promoting culturally relevant lived experience-led innovations. This could mean a program in Fiji, for example, that blends clinical therapy with indigenous healing circles, or a project in Indonesia that trains health leaders and faith leaders to support congregants' mental well-being. By grounding initiatives in the local culture, we ensure they resonate with people's values and realities. And by supporting local capacity, we aim to make solutions sustainable. Our role is not to impose, but to facilitate and support, to connect communities with resources and knowledge while supporting them to lead. So these elements I have spoken of: co-creation, community-rooted care, multi-level engagement, non-coercive practices, and locally led solutions, together really form a rights-based and inclusive approach. All of them is a conviction that people with psychosocial disabilities have the same rights as anyone else, the right to freedom and to make decisions about their own lives in the community. In summary, CBM's work in mental health and psychosocial disability really envisages a world where people with psychosocial disabilities live with dignity, connection, and choice, supported by inclusive communities and rights-based systems that foster well-being. Everything we do, whether it's at the village level, support group, or a policy input to a government, is orientated to making that a reality. The shift we're discussing today is ultimately about reclaiming rights and reimagining what mental health care can look like. It's a shift from seeing people as objects of charity or recipients of medical care to seeing people as agents of their own lives, as friends, as neighbours, colleagues, and leaders in our society. It's about moving away from segregation to inclusion, from paternalism to participation. And it's about collectively saying no to locking people away and denying their dignity, and saying yes to building systems of support that are compassionate, personalised, and supportive. This transformation is really gaining momentum across the Asia-Pacific region. As we'll hear in a moment, countries are really pioneering new approaches, from peer support initiatives and community clinics in villages to national advocacy for legal reform. It's really happening from the ground up. So in the next part of this webinar, we'll hear concrete examples from several countries, including Fiji, Indonesia, Malaysia, and Nepal, where stakeholders have really embraced a rights-based approach and are making tangible progress. Each speaker will share how they are building inclusion on the ground, whether it's through establishing community-based services, mental health laws, or training providers in human rights. So in closing, I want to emphasize that this movement is truly about hope and possibility. It's about proving that there are better ways to support mental health than the old practices we have inherited. And by reclaiming rights, we really open doors to employment, education, to full citizenship for people who have long been excluded. So thank you all for your attention, for your commitment to this cause. I'm very excited to learn from the upcoming examples and discuss how we can collectively push this transformation forward. And with that, I will hand over to our first speaker, Sarah in Fiji. Thank you.
Thank you. Sorry, I'm just trying to get this. Thank you. Greetings to everyone, and thank you for this opportunity to speak today. My name is Sarah Osborne, and I'm a proud advocate and survivor from Fiji. And I'm working with the Psychiatric Survivors Association, a national organization led by and exists for persons with psychosocial disabilities. Today, I'd like to speak from our experiences in Fiji and explore two very important questions. How can rights-based approaches to mental health be ensured in areas without a mental health system or in low-resource settings? And how can people with lived experiences meaningfully participate in a rights-based mental health system? So what does it mean, a rights-based mental health system? A rights-based approach means that people with psychosocial disabilities are treated with dignity, equality, and respect, and not as patients to be fixed, but as rights holders with choices, voices, and dreams. In the Pacific, in Fiji and the Pacific, here we are still very much dependent on the medical system, the health system, as it has been the only option available for us in previous years till date. And for us to provide so that they can choose, because when it comes to rights-based model, you have the right to choose. And because we do not have a lot of non-medicinal therapies, we still give the members their rights to choose. If they want to use the mental health system that is currently in place, they are most welcome to do so, if that's what they choose. But then at the same time, we advocate to ensure that the mental health system in place is aligning to the CRPD and not violating their rights. And luckily for us here in Fiji, though we have an existing Mental Health Act 2010, we ratified CRPD 2018. And organization, national, what we do is we do not use the Mental Health Act because it dictates, it makes us voiceless. It talks about how we should be treated. It does not give us supported decision-making or the rights to make our own decisions. So even in places without a full mental health system or having laws existing, mental health laws existing, and where resources are low, we must still protect human rights. And this starts in the community. So majority of the work that we do is based in the community. And like I mentioned, I would like to share a lot of Fiji's experience, the work that we do. In Fiji, we face many challenges. Limited services, the stigma is still high, and this is the only psychosocial disability organization in Fiji, and the laws that still reflect PSA cannot wait. We do not want to wait. Okay, we do not want to wait because otherwise we'll continue to suffer and be left behind. So some of the works that we are doing around this area is peer-to-peer support and community rehabilitation. Peer-to-peer support is one of the major work that we do. And this goes down to empowering members, helping them understand the nature of the impairment that they have, what type of support that is available, and helping them access these mainstream services that they have the right to access. For example, social protection from the government, the housing assistance, and even down to the basic things like applying and filling in the forms. Filling in a form for if they were applying for something. And at the same time, in our organization, we have established community, at the moment, we're still calling it community watch zone. We're still trying to find a friendly term, but it is working in the community whereby in outlying areas where there is no mental health system services available in that particular location, we train community members and we work with the nearest hospital hospital and the law enforcement officers on the ground to look after the members. And when I say looking after the members, it is ensuring that they have access to meals 3 times a day. It is ensuring that they are not becoming victims of any form of abuse or assault. And if they do that, there is justice given to them, that they are provided with the legal support that they need, and we ensure all these things happen. And it's not only up to that, down to keeping themselves, the hygiene of a person, cutting their fingernails, trimming their hair, and keeping the environment, the house clean. We train the community members to do this work for us, to help the members maintain and not go into a relapse state. And apart from that, the community watch zone here in the organization, we have our community awareness, our training, and within the community awareness, it is mainly focusing on the rights for persons with psychosocial disability, not only into the communities, but to the different ministries, to the different stakeholders that we know that can support persons with psychosocial disability. And it is a person-centered approach. We're putting the members first, and the work we do is not us assuming the needs of the members. Majority of the work we do is consulting the members, understanding what are the challenges and how they think we can help them, rather than providing a type of support that we think that they need. And it differs for people who live in semi-urban areas, people who live in maritime and rural areas. And so not only we are doing this awareness, we are also training law enforcement officers so that they understand rights of persons with psychosocial disability, using the Disability Act and the CRPD that we have to educate them so that they are not violating the rights, so that they know how to provide support. And our training advocacy around disability inclusion or psychosocial disability inclusion is not only to the law enforcement officers. We've moved into health settings like hospitals, the Ministry of Health, providing this training so that they have a better understanding of our rights. Because otherwise, all persons with psychosocial disability in Fiji, they automatically fall under or is under the umbrella of the Mental Health Act. And they are voiceless. Their lives are dictated. And also, another very important thing that I would like to share with us is legal advocacy, ensuring that we are not only empowering members, empowering families and carers and communities, educating them, and raising awareness at national level, but at the same time, we need to be advocating for law reform. We need to be advocating so that for members who choose mental health system, the system is improved, the facility is improved, the services is improved. Though we would really love to move into rights-based model straight away, but I do understand that it will take years even for us to ratify the CRPD and have a Disability Act. It took a long time. But my concern and why I am saying this is because I worry about those who are still choosing to access mental health services that is existing in our countries. We need to advocate for these services to align to the CRPD, whatever laws they have, to align to the CRPD, ensuring that people with psychosocial disability, they make their own decision with good informed information support, so that their rights are not violated. And also at the same time, for us here in Fiji, we've been advocating for the removal of some terms like the unsound mind, and also pushing for supported decision-making, not only in the area of accessing health services, but other areas. For example, the electoral laws, as well as education and employment. And also in our organization, through some small grants, we have helped members start their business so that they can also become financially independent and confident. And we all know, both if we choose to access mental health services or rights-based approach, budget allocation need to be there so that you are able you are able to access the services that you need so that you are able to live a life just like any other person, to be able to afford your meals, your proper housing, and not to live on the street, for example. For us, we believe in the power of lived experiences. We believe in nothing about us without us. People with psychosocial disabilities know best the kind of support that they need, and they should lead the design of programs, services, and policies. They need to be included. Their inclusion must be real and not just some for ticking a box to meet donor requirements or government requirements, or allowing government stakeholders or whoever to use OPDs or persons with psychosocial disability to gain, as this has been some of the experiences that we've been having. Their contributions must be respected. Their voice must be heard, not only be heard, but be validated as well and be included. And their participation must be valued. In terms of mental health laws that harm, in many countries, including Fiji, many mental health laws still allow false treatment, substitute decision-making, and institutionalization. These practices are not good practices, or are not, they are not rights-based practices. They strip away the good future of persons with psychosocial disability. They make them homeless. They make them as subjects or victims. They treat them as charity cases. And this must stop. Okay, robbing of people with psychosocial disability of their freedom to have their own families, to make decisions if they want to take family planning, or if they want to have their own children. This must stop. Governments must ratify and implement the CRPD. Okay, not just in words, but in action. And also we must move away from treating people as objects of care and start recognizing them as leaders and change makers. I really agree with this line, because for us, before I started off as the office manager, we had somebody who wasn't a person with psychosocial disability sitting in this position. And we've seen the difference in the leadership when there's an experienced person, when the movement is led by people who have experiences, compared to having somebody who does not have the same experience, or the experience people with psychosocial disability go through. What needs to be done? We need to have supported or support user-led organization. We need a lot of PSA in areas that have low resource or lack of access to mental health services. We need a lot of organizations like PSA. Why? Because they should be the voice. They have been through the experiences. They know their needs. They understand their needs. And and no one will be able to tell their stories better than them.
Yeah.
And yes,
Yeah,
my time is up.
Sorry, I hate to jump in, but I have to, I'm
It's
afraid.
all good. It's all good. I think I covered most of it.
Thank you very much. Yeah,
Thank you.
fantastic. Thank you very much. Thank you. Okay, in the essence of time, I will hand straight over to Yeni Rosa. Yeni Rosa is the chair of the Indonesian Mental Health Association. Yeni, over to you. We can't hear you, Yeni.
No.
Yes, perfect.
Okay. Right. Okay. My name is Yeni Rosa Damayanti. I'm chair of Indonesian Mental Health Association. This is OPDs based in Indonesia. We have several branches in many provinces in Indonesia as well. I would love to talk about our own experience in Indonesia. This is Indonesia context in which the discussion on psychosocial disabilities and mental health is nearly zero when we first jump into this space. So what I would like to hold on a minute. Okay, sorry. Yeah. So what does it mean, the human right base, when we are talking about mental health or person with psychosocial disabilities? One of the things that we must be clear is that as a human who has rights, our rights is crossing all aspect of life, including it's not only medication. Medication is only one aspect of our life, but we need all other aspect of our life, including housing, employment, livelihood, political participation, housing, social protection, etc., etc., etc. That's the basic premise that differentiate mental health organization, differentiate between patient groups to disability organization. This is two different distinctive. While the patient groups focus on the medical services, disability groups or psychosocial disability groups focus on all aspects of life of person with psychosocial disabilities. So this becoming interesting because our needs in other aspect outside of the health is intersectional with the needs of other disability groups. The blind people, the deaf people, the physical disability people all have barriers in the accessing many sectors of life as well, including housing, including employment, etc., etc. Then in them, we found allies. So when we are fighting for other aspects of our life outside of the medical services, we will find a great allies and strength when we join the cross-disability movement. As a cross-disability movement, for example, like my organization, Indonesian Mental Health Association, we work very closely with cross-disability movement Indonesia in advocating many regulation, many policies in Indonesia, including the policies on the social protection, for example, including the policies on the reasonable accommodation in the education, for example, including when we talk about employment, for example, when we talk about so many other aspects of life, including the national action plan on person with disabilities. So we work with them because if we only talk by ourselves, we are not strong enough. Mental health or psychosocial disabilities is been hold or stuck in medical model for a long time up until now. But the disability movement, they've been freed from the medical approach for a long time too. So by joining them, we've been in the same place with them, in which human rights are the basis of the movement, because human rights are the basis of already more progress other disability groups. So in here, I would like to emphasize it is important for organization of person with psychosocial disabilities to join hand in hand with other disability organization. When we talk about, for example, when we talk, and not only with organization of person person with disabilities, I mean other disabilities, cross disabilities, but also with other groups too. When we are talking about deinstitutionalization, we are talking about the violence that happening in the many mental institution in Indonesia, both in the medical setting and non-medical setting. We also embrace the human rights group in Indonesia. We also embrace the women's groups in Indonesia. Because what is happening in those institutions is not only considered a violation based on CRPD, but it's also considered violation by other convention, human rights convention, for example, CEDAW, even CAT, Convention Against Torture, we started to campaign using the Convention Against Torture to talk about the institutionalization in Indonesia, and it gathered attention not only from the disability community but from the human rights community, including the Ministry of Human Rights. So the point is that we have to build allies. So we are not fighting about this alone, and also when we are talking about deinstitutionalization, one of the things that we learn from a person that from a still developing country who do not really have a social protection scheme that good enough for the citizen, the issue of social protection is very much linked up with deinstitutionalization. We cannot talk about deinstitutionalization without advocating for the proper social protection. So that's one of the things that we work in Indonesia. As also one of the groups that we can relate to and cooperate to is the women's group. As a person with psychosocial disabilities, as a woman with psychosocial disabilities, we face a lot of discrimination, not only as a person with psychosocial disabilities, but as a woman as well. I mean, for example, the issue of the sexual and reproductive health of women who are held in the mental institution in Indonesia is a big concern. By involving the women's groups, we can strengthening this issue as well. So yeah, that's the point is it is very important for us as organization of person with psychosocial disabilities to expand our network, to expand our issue. So there are many benefits of that. Not only that we gather allies, but we are mainstreaming the issues to the central agenda of other civil society groups and other government. Right, with another, how do you call it? Yeah, another one that I'm looking for the list of the questions here. This is the question, the last question. How can we bring right-based mental health support where there are no or limited organization of person with psychosocial disabilities? No, can't. You need to build organization of person with psychosocial disabilities because no others than person with psychosocial disabilities can speak up for person with psychosocial disabilities. So this question is, how can we bring right-based mental health support? By helping to form a psychosocial organization in each countries. This is how do you call it? No question about this. This is very important. I hope the CBM and others also would do this. But if it is very important, if there is none, for example, like in Pakistan there's a huge women institution. There are 1,500 women with psychosocial disabilities who are held in the non-medical setting mental institution in the Karachi, 1,500 women, and they've been there locked up for, well, in Indonesia we have also example like this, but not to this scale. 1,500 women in one place held for years, up to 12 years, 15 years, etc., etc. There is zero organization of person with psychosocial disability in Pakistan. How do we do that? Of course, the first is that we have to build, but we also can work together with the women organization in Pakistan to raise this issue, and hopefully they will agree to to work in this issue too, because this is the thing that I would like to say. Ain't I a woman? Aren't we a woman? So we are not only a person with psychosocial disability, but am I a woman? Ain't I a woman? Aren't we a women? So that's my, my
Thanks,
speech.
Jenny.
Back to
Thank you. Thank you very much. Okay, some fantastic points there, and hopefully we can come back to some of them if we have time at the end for discussion. I'm going to hand you over now to Anita, the president and founder of MIASA. I hope I am pronouncing that correctly, Anita, based in Malaysia. Over to you.
Thank you. Thank you very much, Ben. Hello. Hi, everyone. Good morning, good afternoon, good evening. Thank you very much, first and foremost, CBM and MHIN for organizing this. Very, very happy, very humbled to be part of this initiative. Ben, if you could help me out, can you see the screen? I would like to share my slides.
Yes, we can see the screen.
Okay, all right, awesome. Okay, so I will hopefully guide you guys through my presentation via the slides. I'm sure many of us are also visual people, and I would like to first, of course, send my appreciation and solidarity to Ben, of course, first and foremost, Yenny, and also Sarah earlier, presenting on Fiji and also Indonesia on the context of everyone's country. And this is exactly what I would like to do as well today, to share with all of you a little bit about the work that MIASA Malaysia has done, obviously, so that we can all see, maybe providing some ideas that if you have not implemented this could be something that could work in your country context as well. So echoing, Ben, really what you said earlier, to rethink mental health, and obviously this is a human rights. It's a fundamental human right, and so this will be my area of focus today. Now, before that, everyone, I would like to just introduce a little bit of MIASA so that you also understand where I'm coming from. So I'm Anita. I run MIASA Malaysia. It has been 9 years now. But 9 years in this space really seems like 50 years, to be very honest. Blood, sweat, and tears. I'm also a person with lived experience, or preferred term, a person with psychosocial disability. I've been doing this for 9 years. Previously a former investment banker, so been in the corporate world for a very long time. We pioneered peer support in Malaysia. We provide about 25 support services in the community. We continuously strengthen, develop these various support services, because as we know, everyone is unique. What helps you might not help me, and vice versa. So this is something that we continuously strive for. We are very much overstretched as we speak, because the support services that we provide are very much broad-based. We also run, which I will show you in a bit, in an activity center, crisis management center, 24/7 crisis helpline, WhatsApp line as well. So our pillars of services is awareness, advocacy, and support. Lots of gaps, really, but this is just something that I would just like to highlight in terms of funding constraints. Of course, unrestricted funds are not available right now in Malaysia. What more, continuity of funds, capacity building still being that gap, stigma and discrimination still being very persistent. Of course, accessibility is a huge issue here in Malaysia. Lack of a sustainable model. I think we all know this. Predominantly, in Malaysia, mental health is still under the medical model of care rather than rights-based, inclusive, person-centered, where we value dignity, autonomy, respect. So very much in our work, we strive to amplify the voices of people with psychosocial disability, and of course, dignify their lives. Of course, coercive practices and treatments very rampant, and which, of course, is where we say mental institutions are still, standing. A lot of opportunities. So I'm just going to go ahead and go into what I would like to share. So when we talk about, humanizing mental health services in Malaysia, we began in 2017, so about nine years right now. We have established our MIASA Malaysia Clubhouse model across the nation. And we are the first one. It's a peer-led crisis management center and activity center. It's a drop-in center. Anyone can come in. It's a safe space for people with psychosocial disabilities and their family members. We have about 2,000 plus volunteers across the nation. So our modus operandi is voluntary basis. We have crisis responders across the nation as well. So a big shout out to them. Thank you very much for the work that you do. They're trained in crisis management, trauma-informed care, mental literacy, suicide prevention. There are some of them suicide first aider, peer support specialists. We provide, as I mentioned, 25 support services. These are some of it, arts-based classes. So we do art, we do drama, we do speech, we do pound fitness class, fitness activities. We do faith-based classes as an example as well. And of course, we have been very much involved in many roundtable discussions, you know, internationally, globally, and also obviously nationwide. We are also part of the Mental Health Advisory and Promotion Council, where we report directly to the health minister in Malaysia. We've done many roundtables with ministers, with policymakers, very much involved in the roadmap to mental health, you know, action plan, being in technical, you know, working groups, clinical practice guidelines, and as an example for the management of schizophrenia adults, so on and so forth. We do a lot of training as well, and that is one of our ways to capacity build and also humanize mental health services. We do crisis management, trauma-informed training. We do intentional peer support, suicide prevention, and also intervention. We run, you know, independent research projects, policy recommendations, etc., webinars as an example. We've also collaborated with being part of TCI since 2018, which Yenny is a big part of it, of course, and her organization. So we partnered with TCI in 2019 for a stakeholder meeting for the first time in Malaysia. So we were able to you know, come out with 5 resolutions, and one of it was closing down mental institutions. And this is not something that is being discussed openly. So very, very happy for that progress when it happened. And also being involved in the global front, where we, you know, we were able to present on No Restraint on our work in Trieste in Italy in 2019. We do a lot of innovations as well. So via podcasts, radio shows, TV shows. Our most recent was last year via our International Stigma Conference, where we had a panel discussion on deinstitutionalization in mental health care as well. In terms of accessibility and inclusion, as much as possible, we run a 24/7 crisis helpline, as mentioned, 24/7 crisis WhatsApp line. We also have our own mobile app, which I hope which is hoped to be launched this year, which is disability inclusive. It's a peer approach. It has a panic button. We also have our own website, which we have revamped. Very, very happy with this newer outlook and information that we have made it more current in that sense. And we also work a lot with the marginalized and vulnerable communities, especially the homeless folks. Although there are, you know, in instances where we reach a dead end, but that is where the opportunity lies as well. Shelter homes in Malaysia do not accept people with psychosocial disabilities, and so that's why that has been a challenge and sometimes dead ends as well for us. And we've also been involved with the Geneva Health Forum 2022 on increasing or improving accessibility for mental health care in Malaysia, in 5 countries, including Malaysia. And what we do as well, you know, every single week is also provide essential food, you know, baskets, etc., for the bottom 40 income earners, and try to also have them part of our initiative. So we empower them as well in that sense. And we also work with different industries as well. Mental health in the workplace is one of our ways to provide this accessibility. We run about 200 plus programs every single year. Our annual sports event is something that we run, obviously annual, so every single year. And last year, just to show, we ran our disability inclusive sports event. So it was, you know, from all various categories of disabilities. We did track and field. As you can see at the very bottom, we did sitting volleyball. Volleyball is very, you know, popular in Malaysia as well. We had fun runs and just different sports event as well. We are very involved, as I mentioned, with the ministry. So these are just some pictures of our involvement in roundtables as well. And of course, as mentioned, we are also very involved with the different stakeholders. We have been collaborating with Kuala Lumpur, KLCC, you know, the tallest twin towers in Malaysia, as a partner for 3-4 years now, where, you know, mental health is being discussed at the biggest mall in Malaysia. And we're able to create or have, you know, calm areas. We did a podcast this year right smack, within KLCC. We've also done, rides, convoys. I think a couple of years ago, as you can see here, with super bikes, Harleys, etc., on ride for suicide prevention and mental health. So providing awareness really to the different communities across the north and also central of Malaysia. So many different conferences that we have ran or organized. And also one of the most recent initiatives, well, not really recent, but in 2021 is the National Advocacy of Mental Health Association, where is the first peer-led alliance. So many different disability movements or associations coming together, under one roof in that sense. And also as a way for us to further capacity build, we also have collaborative scholarships in partnerships with different foundations for masters and also PhD that we have done. And so in terms of innovation, I know I'm speaking really fast, but I really want to finish on time, is also we do podcasts. So we have run I think about 50 podcast episodes now, where we talk about humanizing mental health services, fighting stigma and discrimination, deinstitutionalization. What does that look like? What are some solutions moving forward? And of course, campaigns nationwide, many campaigns every single year. And one of the campaigns that I am especially proud of is #UnlockYourStory, storytelling by people with psychosocial disability and zero coercion. It was a very difficult campaign to run. A lot of backlashes that happen, especially from the psychiatric fraternity. But again, we are here to, we're not anti-psychiatry. We are trying to capacity build. We are trying to harmonize. We're trying to provide the education so that once and for all, we can close down mental institutions and we can dignify the lives of people with psychosocial disability. And, language, vocabulary is very important to us. So we work together with disability great, respectful and appropriate disability language. And so I will end here. Thank you very much, Ben, for the opportunity, and everyone. I hope that helps. Thank you very much.
Thank you so much. Fantastic. Amazing to see all of the work you're doing. Okay, I would quickly hand you over to Rita. Rita is our Senior Program Officer and Mental Health Focal Point at our CBM Global Office in Nepal. Rita, over to you.
Thank you, Ben. Thank you for organizing this webinar, and thank you for this opportunity. So I will be switching off the video camera because my internet is not that good, internet connection. So forgive me for this. Okay, thank you once again. I'm Rita. I'm working with the country office, CBM Global Country Office in Nepal. And so today I'm going to share more about what we are doing in Nepal, particularly in terms of the ensuring the human rights-based approach into the mental health. I would like to thanks to Ben for highlighting about the CBM Global's mental health and psychosocial disability strategies, and most of the information that I'm going to share, the Ben has been already highlighted in most of the information that whatever we are doing, that we are mainly focusing on the human rights-based approach, and then our mental health and strategy, mental health and psychosocial disability strategy are the guiding document for us in this program. So next slide. Okay, next one. Okay, in the context of Nepal, we are the we have the federal government system, and also we have the we are working through all the three tiers of the government in Nepal, and we have a very strong disability movement that through the National Federation of the Disabled, we have very strong positioning in the country, in all the provinces. And at the same time, we have one very pioneering organization, or only one OPD organization of psychosocial disability, with whom we are working in partnership in the mental health program. And Nepal has ratified that the UNCRPD is optional protocol, and we have that National Mental Health Strategy 2020, which also ensures the human rights-based approaches in our mental health program. And recently we had a Supreme Court verdict that ensures the human rights-based mental health care program, respecting the human rights, dignity, and choice. This is the very historical decision made by the government, made by the from the Supreme Court, but yet to see the implementation in future. So we'll be working for this implementation of this verdict as well. So next one. So regarding the guiding principle, our mental health program is guided by CRPD, WHO, Quality Right Initiatives, and Disability Movement. And then our work is grounded in the human rights, social justice, and the leadership of the people with lived experience, that are people with a psychosocial disability or mental health condition. We mostly focus on the human-centric approach that upholds the autonomy, dignity, and freedom of the choice. And to make this happen, and then to ensuring whatever we are doing, that we try to ensure and to ensure that nothing about us and without us. So engaging person with lived experience, psychosocial disability in every steps of our work is the key and fundamental for us. So next one, please. Next slide. Okay, as Ben also has highlighted in that brief introduction about the CBM level, we work together with the peer support groups, self-help groups, and then we also work across disability movement, OPDs, and also working with the advocacy, joint advocacy campaigns. So mainly focusing to the strengthening the knowledge and skills skill on disability rights, leadership, and advocacy for these groups, and linking with the different kind of services and opportunities and economic empowerment, also other different kind of things, and then also promoting them as a self-advocate and engaging them to lead the advocacy. We are supporting from the back, and they are they are working as a lead advocacy in the driving seat, and they are the one who are leading the advocacy in all our mental health programs and beyond the mental health program, in even other community-based inclusive development programs. And also, we are also equally advocating for the inclusion of the person with psychosocial disability within the disability movement. Still, there is very less or no representation of the psychosocial disability within the OPDs and disability, cross-disability movement. So we are also advocating for that together with the person with lived experience. And in terms of the partnership and collaboration, we are partnering with the OPDs and disability movements, and then most importantly, OPDs of the psychosocial disability, and then government stakeholders, government systems, and service providers, that more focusing to the inclusive laws, policies, services, systems that should, our focus is that to influence them to ensure the human right-based approaches and the lanes in the policies, laws, and other services and the systems. Okay, next one. Okay, so while doing so, we are ensuring the inclusion of people with a disability, the psychosocial disability at all the level of the project cycle management, working through the advocacy movement, and if you see in Nepal, that deinstitutionalization, we are promoting the deinstitutionalization through our programs, but nowadays in other countries like in Europe and in the Asia Pacific, you are advocating for the deinstitutionalization, and then they are working on the opening the gate and more focusing on the community-based program. But in the context of Nepal, now the institutions are increasing. So government in some way, somehow government is also funding for that. So we are trying to sensitizing the government about the human rights treaties and human rights-based approach, and focusing to convince and to advocate them to not to fund and to stop the institutional practices. But it's a long way to go, but it's very increasingly going to have an institutional institution funding for the institution, promoting the institution, even if some policy document and annual plans and all, they are very clearly highlighting the funding opportunities and for the institutional mental health program. So we are also advocating through our program not to fund or the digitalization practices. So we have a different kind of other initiative like a child and adolescent mental health and suicide prevention.
Rita, I think we've lost you. Have you muted, or is it a connection issue?
I think it might be a connection issue.
Okay. Okay. Unfortunately, I think Rita has dropped off. She might rejoin if her connection comes back. I think something just to highlight actually from Rita's presentation is the alarming fact, I suppose, that she raised, which is the reality still in many contexts, that while this work and what we are discussing today is really growing momentum and there's a lot of fantastic work happening, at the same time as that, we're also seeing in some contexts that institutions are at best continuing to be supported, but actually in some scenarios even being scaled up and continue to be built or implemented. And I think this really brings to attention the fact that we need to have some very focused and targeted advocacy. We really need to be demonstrating that and documenting that alternatives at community level work. And that also our advocacy and engagement at a policy level also needs to extend to donors. Because quite often they're the ones who are supporting governments in scaling up institutional models. Okay, thank you to all of those who have presented. It's fantastic to have such a diverse representation across different countries and different areas of work. We are a bit over time. We still have some time for me to ask some of you questions. So maybe, Sarah, if I come to you first, I'm actually, if all...
Hello, Ben.
Hi, Rita.
Sorry, that I lost the connection.
It's okay. If it's okay with you, we've moved on to panel questions.
Yes, sure.
Yeah. I'll come to you for a few questions. So if there's any important points you want to add, we can go over them then. Sarah, I was just wondering from what you were talking about, I suppose something that might not be clear to everyone is outside of healthcare, more specifically, maybe looking at kind of social protection and education, for example. In your context, what barriers do people with psychosocial disabilities face in accessing those types of services and supports?
Barriers that people with psychosocial disability face in terms of accessing these mainstream services or support is that many of these service providers, they don't see people with psychosocial disability, they don't see them as persons with disability, and they don't think that rights of persons with disability, the Disability Act does not apply to protect people with psychosocial disability in Fiji. And also, though we have ratified the CRPD, most of the legislations, policies we have in place have not changed. Has not changed. It is not aligned to the CRPD, and with the terminology that is used in our main constitution, unsound mind. And this unsound mind refers to people with psychosocial disability. So that is major, or one of the challenges of accessing services for us here in Fiji. They are treated differently, not equally as many other, even the other disability, the other impairments. When it comes to people with psychosocial disability, they are very much left behind and not treated with respect or any form of equality when it comes to accessing services. It is because of that they are not really recognized as persons with disability, but rather patients or people with mental illness. And because the stigma that is associated with mental health, mental illness in Fiji is still very high, that's the reality and the challenge that people face.
Yeah, I think that's
And
something.
maybe just to add in another bit is that.
Sorry. I was just saying, I think that's something we see a lot in both in terms of, exclusion from policy at a systemic level, and then also, exclusion due to stigma and discrimination, both at a systemic level and a community level. Just on that, I wonder maybe if we could move to Anita, and I'm just wondering, because this is quite a common, what Sarah has shared there is quite a common experience and situation in many contexts. But what type of advocacy strategies have you seen or been effective maybe in pushing for kind of more human rights-based mental health reforms and inclusion cross-sectorially?
Sorry, Ben, thank you for the question. Advocacy strategies, I think specifically for the work that MIASA does would be our lived experience leadership. It's really the heart of who we are. So we, empower people with psychosocial disabilities. And if you look at our work, everything that you see is done, by people with psychosocial disability. And so that's how we really paved the way. The other thing, and it's a very powerful form of advocacy. And the other one would be strategic collaboration. How we have been able to do the work that we do, Ben and everyone, is through partnerships and synergies, all these different collaborations with different stakeholders. So through that, we have been able to push for, just a different reforms, and also bare minimum, people start thinking about it, right? And so the hope is always to be able to spur actions at all levels. And thirdly, obviously, is policy engagement. We have been very fortunate, but however, it is through the hard work that we have been doing. So really doing the hard work, making ourselves visible, to be heard, and we learn every day, and we build the network. So it is really, blood, sweat, and tears. So that could be a strategy. Thank you, Ben. Hope that helps.
Thank you. Yeah, absolutely. I think, your point there around lived experience to leadership, really supporting both individuals with lived experience and I suppose organizations of people with psychosocial disabilities, really supporting them in strengthening, I suppose, their organizations or amplifying their voices in these spaces is really important. And I think something to highlight that we're really trying to do more at CBM, and I'm sure this is the case for you as well, is sometimes knowing actually when you need to step away, and when actually you're better represented by, an alternative voice, so by somebody else with lived experience, or for us especially as I suppose, not specifically as an OPD, but as an INGO, knowing actually when maybe, okay, we need to make that relationship and make sure that that person or individual has a seat at the table, for example, even if that means that we need to not be there or we can't be there. Okay, Jenny, something I think you were getting to when I cut you off at the end of your presentation was just around, I suppose you answered the question already around kind of how can we bring rights-based mental health support when there are no limited organizations of people with psychosocial disabilities. And I agree with you. You said, we can't really when there's not that representation. And I suppose my question then for you is, in context, maybe like Pakistan, where you mentioned, where there are no identified organizations of people with psychosocial disabilities, how can we support, I suppose, groups such as the women that you were discussing about, to come together to advocate, to represent themselves in the movement and other people with psychosocial disabilities? So I suppose really, how can we identify those access points, and what's the best way for us to support them without being prescriptive in a way where we're saying, you need to set up an organization? I can't hear you, Jenny.
Earphone is not really working. Yeah, well, it's really difficult because what? Stigma against person with psychosocial disabilities is everywhere, including within the disability movement, including within the human rights movement and women's movement. None of them, none, think that detaining person with psychosocial disabilities in mental institution is wrong. None of them. They thought that it is a good thing. So somebody must convince them that it is not so. How? Because for most people, person with psychosocial disability is the others. They are less than human. Therefore, they do not have the equal human rights like everybody else. So how do you do that? I mean, well, of course, the one that very important is to build up a strong DPOs in that country. But if you cannot do that, probably you can work with groups that really closely related with the issue of human rights. For example, like disability groups, women's group, women with disability groups. But you have to use certain strategy to convince them, including funding strategies, for example. That if you want to receive money from us, you have to involve person with psychosocial disabilities. One of them. And also probably, if there is no strong psychosocial disability organization in that place, if you have a meeting, if you have a meeting with different disability groups or different other civil society groups in that place, you can invite person with psychosocial disabilities who's already kind of like established the movement of person with psychosocial disabilities in other countries to introduce the idea to them, because one of the problem is that most of them do not have any experience to how do you call it, to work together to meet with a person with psychosocial disabilities who's capable, to advocate for themselves. No, they have no experience of that. So their perception of person with psychosocial disabilities is very, very discriminated, stigmatic, and very low. So it is important for them to get in touch and to familiarize with how the person with psychosocial disabilities can do. Well, of course, there are many persons with psychosocial disability who are successful in many countries. The problem is that none of them would like to come out. Why? Because of stigma. For example, like in Indonesia, if you come out that you have a psychosocial disabilities, there's always a risk that you will lose your job. So this is a problem. How to make person with psychosocial disabilities to acknowledge that they have psychosocial disabilities. If they are not ready inside the country, bring someone from outside, talk to them, and hopefully, the world is a big global community. I mean, the learning process is not only within the countries, but through other countries. I have to admit that I learned a lot about psychosocial disabilities through several meetings set up by, well, at the time, Bargavi, in in many places, including in Bangkok, in which we kind of like sharing our experience and forming our identity as person with disabilities and person with psychosocial disabilities, and where is our place, on earth and within the disability movement. So that's things that
Thanks, Jenny. Yeah, thank you. I like the term you used there, global community. I might rob that from you. Rita, so I suppose we've spoke a lot about, what are the challenges, and but we've also heard from Anita and from Jenny and others about how we can overcome them in terms of, through our advocacy and lived experience to leadership. Another thing I think that's really important, and that we've also mentioned today, is around demonstrating that what we're doing at a community level works. And a huge part of that obviously is measuring the impact. So I'm just wondering how in the programs that you support, do we measure the impact of these rights-based approaches at a community level and in our programs at a community level?
Yeah, thank you, Ben. Yeah, basically, in order to measure the impact of the human rights, so we have a different kind of human right focused tools and methodologies, and then that we can use for the that can be adapted or contextualized to use the to have the to use that to measure the impact. And then particularly we need to see the impact in the different 3 or 4 levels. One is the like individual levels, how the changes has been tackling the changes in the individual level, their social inclusion, their participation, and whether there is a reduction in the self-stigma or not, and then whether they have the increased access to the resources or services or not, and then taking the benefits from the having the access to the benefits in the different opportunities, social security or other kind of health, education, and those things, kind of opportunity in the individual level. At the same time, at the community level also, we need to measure the impact, whether the stigma has been reduced or not, and behavior and attitude and behavior of the community towards the individual with a psychosocial disability. That and also the level of the awareness we can measure in the community level, and also health seeking, mental health seeking, like a behavior and practices, whether that is changed or not, because of stigma, in most of the cases, people, they don't want to seek the services within their community. They wants to go to the outside the community or somewhere else where they are. They don't need to be worried about their identity or their that confidentiality and other kind of things. So we need to ensure the whether the impact happen or not in the community level. At the same time, in the system and the policy level. So we need to see the whether there is a changes in the policies and practices. Having a policy is a very easy kind of things in most of the cases, but implementation in the practice is the very challenging. And then whether the resource that policies implementation is in place or not, whether resource allocation is increased or not, whether that service provision has been focusing on the human rights approach or not, like a reduction in the inhuman treatment, coercion, is there or not after the our program implementation, and also to see the whether the accountability of the duty bearers and the service providers increased or not, whether accountability and responsibility to ensure the human rights based that service, policy, and system. So we need to have a look in the all the 3 layers of the and maybe the beyond that, we need to go to see the that impact. And while doing all these things, impact measurements or evaluation, we should have the involvement of people with disabilities, psychosocial disability in that process. So from the starting to ending, and throughout the cycle, they have to be the part of the process. So they are the own, they can guide us, and they are the expert by the experience. And so we need to ensure their engagement throughout the process. Thank you.
Thank you very much, Rita, for that comprehensive response. And I think it really goes to show that in order to adequately, I suppose, demonstrate and measure the impact that we are having, with these rights-based approaches, we really have to invest capacity and resources in monitoring and evaluation. And, it's a bit of kind of, if people don't hear about it or don't see it, did it really happen? And in order, I suppose, also to feed into our advocacy, we have to be demonstrating impact. So while it might sound overwhelming to some, everything that Rita has mentioned, it's really very necessary. I know that we have just 2 minutes left. So we're probably not going to have time to get to the remaining questions and answers. What I would say is, and I think Glenn, correct me if I'm incorrect, but I think we can answer these questions on a shared document or something and share them with everyone who has attended today. So if you have any kind of final questions, please feel free to put them into the Q&A function, and we will get back to you with answers. I want to say a huge thank you to Glenn, to Anne-Claire from MHIN Asia for organizing this webinar today. It's been fantastic, and I hope that it is the first of many where we're discussing this issue, because of course this has really just touched the surface today, and there's lots more we could discuss. And we really hope as well that you will all share this webinar from today, and also please provide us feedback on how we can make it better and what you would like to see in future webinars. Also, a huge thank you to our speakers and to our panelists. It's been amazing to hear all of your different perspectives and of the fantastic work that you're all doing. So please keep it up. And a huge thank you from me and everybody at CBM to all of you, both panelists and attendees alike, for all of your efforts in this area. I'm going to steal now Jenny's term and say, as a global community, I think, we really need to continue to champion mental health, and psychosocial disability, and to work on systems and structures that respect human rights, and I suppose that truly belong to and help the people that they serve. So thank you. Have a good Friday wherever you are, and a good weekend. And hopefully we will all speak again soon. Thank you.
Thank you, Ben. Thank you, everyone.
Thank you. Bye, Annie.
Bye. Thank you, everyone.